All right, so we'll get started here slowly, and we'll get right into it. We got a lot of material to cover. So good evening, everyone. Thanks for joining us tonight to this talk that was put together by Thrombosis Canada. So a big thank you to them for inviting myself and my colleagues as well here to give you this. It's entitled Frontline Pharmacists, Preventing and Treating COVID-19, What You Need to Know. So tonight's faculty, we're basically 5 pharmacists from around the country, very diverse group working in different fields of pharmacy. And you'll see, I'll introduce myself right now, and all the speakers will introduce themselves prior to their sections. So my name is Ryan Kerzner. I'm a pharmacist at the Jewish General Hospital in Montreal, where I work in thrombosis and where we developed an anticoagulation stewardship program, but I'm also an antibiotic stewardship pharmacist as well. So basically that means COVID has really been my life for the last few years. And then I'm sure, look, COVID has touched all of us, of course. And so I'll be sharing our different areas of expertise with you tonight. These are my my disclosures. So I do have, I've received some honoraria from a few different companies, and they're on the screen for you to see. We do have disclosure of financial support. So this program has received financial support from Pfizer in the form of an unrestricted educational grant. This program has not received any in-kind support. There are potential conflicts of interest, so all speakers are eligible for an honorarium from Thrombosis Canada, and Pfizer may benefit from the sale of a product that may be discussed in this program. But to mitigate the potential bias, the content of this program was developed by the planning committee and peer-reviewed by Thrombosis Canada. Recommendations involving clinical medicine are based on evidence as accepted within the profession, and all scientific research referred to, reported, or used in the program in support or justification of patient care recommendations conforms to the generally accepted standards. We're happy to say that this program is accredited by the CCCEP for 1.5 units of credit. What will happen is you guys will be asked to do an evaluation after the event, and at some point in the next week or so, probably by the end of next week, you'll get the certificate of participation for everyone who is here tonight. So this is the agenda. We're basically going to be discussing all aspects of COVID, from prevention to treatment to what happens after the fact. So we'll get right into this. These are our objectives for tonight. So we're hoping at the end that participants will be able to encourage vaccination as an effective strategy to prevent or reduce the impact of COVID-19, to describe the role of the pharmacist in the outpatient management of patients with or at risk of COVID-19 complications, select patients who are candidates for treatment of COVID-19 with antiviral therapy, assess and manage drug-drug interactions for patients prescribed an antiviral to treat COVID-19, and to optimize and monitor treatment for patients with COVID-19. So without further ado, I'm going to pass this over to Stephanie, and let me give you control here. There you go.
Thanks, Ryan, and thanks to Thrombosis Canada for inviting me to be part of this panel. So I'm a faculty member at the School of Pharmacy in St. John's, and so my teaching, research, and clinical practice is all in the area of thrombosis and anticoagulation, and I'm a clinical pharmacist with our local thrombosis service. So what I'm going to be discussing is more of a high-level overview, including some adverse events, and hopefully set the stage for the presentations to come. So here are my disclosures. So where are we in terms of COVID-19 cases? Well, we know certainly since December 2021 what our numbers were. However, at that point in time, with the wave of Omicron and the testing that was required and the number of cases, it overwhelmed the system. So certainly case numbers since then are certainly underestimated. However, I think a better reflection is where we are with the current state of COVID-19 related deaths, because those are counted more accurately. So we can see that people are still dying from COVID. So COVID is still an ongoing concern. And we also see that the patients who are most likely to die are the older patients. So they are certainly a group that should be targeted from a vaccine perspective. So would pharmacists fit in the overall strategy of preventing and treating COVID-19? So since the start of the pandemic, pharmacists have participated in and have stepped up with regard to COVID-19 in many different settings and in many different ways. And so this diagram is from a 2021 scoping review of global pharmacist roles in response to the pandemic. So there were 63 studies from over 20 countries identified. So this doesn't include vaccinations. So it did show from a global perspective that pharmacists had roles in public health, information, as well as medication management. And certainly the role for pharmacists has evolved. The scoping review did not include additional roles that have come about since the review, which includes vaccination, which pharmacists have played a significant role in, as well as the assessment, prescribing, and monitoring of the new treatments that you're going to hear about tonight. So what about COVID vaccination and COVID vaccines? So since the rollout in December of 2020, we now have 11 formulations from 6 manufacturers that cover the ages from 6 months on up. And there's been almost 100 million doses administered in Canada to date. And the modeling estimates that these vaccinations have saved over 14 million lives. And we know that pharmacists have played a very key role in the COVID-19 vaccinations. Well, how are we doing in terms of vaccine coverage? So the graph on the left shows the cumulative percentage of the population that have 1 dose. And that's certainly since the vaccination campaign has started. So you can see that's a fairly high number, so almost 84%. However, the graph on the right shows a percentage of the population that have completed a primary series or have had a booster in the last 6 months. And certainly this is the statistic that my province on our dashboard currently displays. So it's more of a reflection of who currently has protection against COVID-19. It obviously doesn't include immunity from infection. But I think it shows that we still have a fair bit of room to move when it comes to vaccination. So let's look at a case that you may see in your pharmacy or in your clinic of a patient that may be a little bit hesitant about vaccination. So this is a 49-year-old patient with a history of unprovoked pulmonary embolism, no other medical conditions, currently takes rivaroxaban 10 milligrams daily. And he's had the primary series of the Pfizer vaccine in the fall of 2021, but hasn't had any boosters since then. So you notice this, and when he's picking up his refill, you ask if he would like to book an appointment for his booster. However, what he says is he doesn't think so, as he's read about side effects from the COVID vaccine and specifically mentions clots and heart trouble. So let's look at those in a little bit more detail. And in terms of COVID-19 vaccines in general, the government of Canada has been tracking the adverse events with all the caveats of adverse event reporting. But certainly what they've shown is that the numbers of adverse events to the COVID-19 vaccines have been small. And recently, there hasn't been any new safety signals that have been identified. There were 2 adverse effects that seem to have been more prominent that may not have been initially expected. So the first of these was the vaccine-induced immune thrombotic thrombocytopenia, or VIT. We don't hear a whole lot about this these days. It was an immune-mediated, or it is an immune-mediated reaction to the COVID vaccine. And it was primarily with the viral vector-based vaccines, which were the ones that were used in the early days of the vaccination campaign. The incidence is still considered to be rare. So from the Government of Canada website, here are the numbers that have been reported up to November of 2022. So you can see that primarily it was with the viral vector-based vaccines, although it has been reported with the mRNA, but you have to take into account these are the raw numbers that have been reported and don't necessarily take into account the number of doses that have been administered, which we know at this point in time have been primarily the mRNA. So the American Society of Hematology has also developed some criteria for diagnosing VIT. And in terms of their criteria, it is in relation to the timing of the vaccine, and it includes any venous or arterial thrombosis. So here are some symptoms that, you know, certainly may be of interest in terms of things that you may want to monitor for in your patient. It also includes a low platelet count. So this may show up as unusual bleeding or bruising, and as well some additional lab testing in order to confirm the diagnosis. And there is treatment that is available if this is diagnosed. So one of the questions that we got asked quite frequently in our clinic at the beginning, when all of this was evolving, was what about patients who have a VTE history or who are currently on anticoagulants? Should they get the vaccine? But what we know is that COVID-19 infection in of itself is associated with non-VIT thromboembolism. That's certainly been demonstrated. And so patients with a prior history of thrombosis or taking anticoagulants should still receive the vaccine. And because VIT is an immune-mediated process, it's not really linked to a history of thrombosis or anticoagulant use. The second adverse effect to emerge was the myocarditis and pericarditis with the vaccination. And this seems to occur primarily with the mRNA-based vaccines. And it does seem to be with the second dose and in younger patients and in males more than females. And it usually happens within a week of most often the second vaccination. Similarly, you can see here with the numbers, on first glance, it looks like it may be higher with the Pfizer vaccine. But again, you have to take into account the number of doses that have been administered of each vaccine. And when you look at all of the doses together, because that's certainly data that is available, there's probably been almost twice as many Pfizer vaccinations given compared to Moderna. So some of the signs and symptoms that you may want to look out for are with regard to things like chest pain, shortness of breath, a fast beating, fluttering, or pounding heart feeling. And the data that is available as of now says that most patients will generally recover from symptoms and will do well. However, we really don't have a lot of information on any long-term data for patients that experience this. I think like many things with COVID, that will be something that will evolve over time. So if we go back to our patient, what would you do in terms of your recommendation to this patient? Would you say he's had blood clots in the past, so should not get any of the vaccines? He's male, so he shouldn't get the mRNA vaccine. He's on an anticoagulant, so should not get it. Or looking at the low incidence and the different clot mechanism, it's more important to prevent COVID and its complications. So you'll see the polling question there. So I'll give you a chance to vote. We'll put up the responses. So not unexpected. Most respondents would say that the patient should get the vaccine. So I'll now turn it over to Darcy.
All right, well, good evening, everyone. So my name is Darcy Lamb, and I'm a primary health pharmacist within the Saskatchewan Health Authority, and I'm based out of Saskatoon. And, for about a 6-month period, January till June of 2022, I was pulled to work with our COVID therapeutics team. So that was our provincial team that really looked at, finding or assessing patients for eligibility for COVID treatment and prescribing these medications. So I have a lot of experience, or at least a short period of time where I had a lot of experience with antiviral treatment for COVID-19, and that's what I'll be talking about today. So this is my disclosure. And as I mentioned, I want to talk about antiviral treatments for COVID-19. And the two most common antiviral treatments that we currently use in the outpatient setting are Paxlovid and remdesivir. And I'll talk about each of these and kind of highlight some of the evidence from the clinical trial data. And we'll start off with nirmatrelvir and ritonavir, which we know as Paxlovid. And when it came onto the market, it was a little bit of a game changer. Simply because it was an oral therapy. So prior to that, we were only using IV drugs, and some patients had to drive, 2 to 3 hours to get to an infusion site that actually had that medication. So when Paxlovid hit the market, this was accessible. It was in community pharmacies and easily available for a vast majority of people. So treatment changed. It became more accessible. So the nirmatrelvir is the actual antiviral component of this combo drug. And the ritonavir is on board because it's a very strong CYP3A4 inhibitor. So it basically boosts the pharmacokinetics of the nirmatrelvir. So the drug itself, the way that it works, it inhibits a certain protease enzyme within the COVID virus. And this enzyme is essential for viral replication. So basically by inhibiting this enzyme, we can inhibit viral replication of the COVID virus. And of course, this drug was studied in the outpatient setting in the EPIC-HR trial. And this trial was a randomized, double-blind, placebo-controlled trial. It was fairly well conducted. There were just over 2,000 patients that were randomized to either the antiviral group or the placebo group. And the drug dosing in this trial was 300 milligrams of the nirmatrelvir, 100 milligrams of ritonavir, and this was dosed Q12H for 5 days. And the primary outcome that was being investigated was COVID-related hospitalization or death from any cause through 28 days. And I want to take just a little bit of time to look at the patient population, because I find the population that they studied in this trial is quite a bit different than the population that we actually use this drug in clinical practice, at least in my experience. So they included patients over the age of 18. When we look at the baseline characteristics, what we see in actuality is this was a middle-aged population. The average age was around 45. Patients had to have a confirmed COVID infection, and they had to have symptom onset no more than 5 days within randomization to one of the therapies. These were all unvaccinated patients, and these were all high-risk patients in terms of progression to severe COVID. I've got the risk factors for progression down at the bottom of the slide here. And roughly 2/3 of patients had at least 2 risk factors. So again, this is a middle-aged population that was unvaccinated, that was quite high risk for progression to severe COVID based on their risk factors. Some of the main inclusion criteria were things like anyone that had a previous COVID infection. So basically the investigators did not want any kind of COVID antibodies hanging around. Anyone with really poor renal function, active liver disease, anyone on really significant interacting medications, among other things. And if we look at the efficacy data, I know this table is a little bit busy, but let's focus on the first row for now. So this is the primary outcome, which was hospitalization for COVID-19 or death from any cause in those that were treated within 3 days of symptom onset. And what we see in the placebo group is that about 6.5% of patients had that primary endpoint. And in the antiviral group, about 0.72% had that primary endpoint. So really there's an absolute reduction in risk of over 5%. And this corresponds to a number needed to treat of around 17 and a relative risk reduction of almost 90%. I will note that in the antiviral group, there were 0 deaths reported. The other outcome that they looked at was hospitalization or death when treatment was initiated within 5 days. And really what we see is results that are pretty much the same. So what that means to me is basically we can use this drug as long as the patients what am I trying to say? We can use this drug as long as their symptoms have been within 5 days. And don't have to have too much concern that, you know, we wait for 5 days versus starting sooner than that. Oops. Go back one there. So this is the safety data from that trial. And I really just want to point your attention to a couple of different things here. So statistically, there was more taste disturbance in the antiviral group and more diarrhea in the antiviral group. And in the trial, they didn't really, I mean, it wasn't that large, right? 3 to 5%. But looking at my clinical practice, so I spent a lot of time talking to people, following up after they've been on their Paxlovid therapy. And what I found is that 90 to 95% of patients were saying, you know, while I was on this drug, I just had this really horrible taste in my mouth. It was bitter, it was metallic, it was, you know, people described it in different ways, but most people were having some kind of taste disturbance. So our group really started telling people up front that, okay, if we're going to be prescribing this drug, I expect you to have some kind of taste disturbance. So it's really interesting to see in the clinical trial that, you know, only 5 to 6% of people actually reported that side effect. And also in my practice, I've seen, you know, diarrhea occurring in probably 3 to 5% of patients. Most of the time, it's pretty mild, it's pretty self-limiting, but there were a handful of people that just had quite severe diarrhea to the point that they contacted us and they said, I don't want to continue on with this drug. And at that point, there's really a decision to be made, right? If we're not that concerned because maybe their symptoms have significantly improved, or you know, they don't have that many risk factors for progression, we might stop the drug. You know, the risk was more than the benefit. But in the patients that we felt, you know, really strongly that they needed this medication because they were such high risk for progression, we would actually treat that side effect with loperamide. And I hate to treat side effects with another medication, but for a 5-day course of therapy in the patients we thought really needed it, I think it's warranted, or at least acceptable. If we turn our attention next to remdesivir, so this is the other agent currently in use in Canada. It's an IV antiviral agent. And so, you know, I see it used quite often in patients who we can't use Paxlovid in, usually due to the drug interactions that we can't work around. But in this case, as I mentioned before, with some of the other therapies early on, there's only so many infusion centers that would have this medication. So some patients have to drive significant amounts of time to get this treatment. So it's not quite as convenient, but it is an available option that's quite effective. And this antiviral agent works by inhibiting the COVID virus RNA-dependent RNA polymerase. And by doing that, it really inhibits that viral replication. So prior to it being used in the outpatient setting, we were using it in hospitalized patients. And it was really thought that maybe a shorter course of therapy could be used in that outpatient setting before they end up in hospital. And this was really what was studied in the Pine Tree trial. So this trial was very similar to the trial set up for the EPIC-HR trial. And we'll see quite quickly here that the patient population was very similar as well. So it was a randomized, double-blind, placebo-controlled trial. There were 562 patients randomized to remdesivir, the antiviral group, or placebo. And the dosing in this trial was 200 milligrams of IV remdesivir on day 1. And this was followed by 100 milligrams IV on day 2, and then 100 milligrams again on day 3. So the infusion itself was run for 30 and up to 60 minutes at a time. And the primary outcome was the same as the EPIC-HR trial. In terms of inclusion and exclusion, you'll see here that, you know, that the patient population was quite similar. There's a couple of differences. So they did include patients that were 12 years of old or greater, but in actuality, the average age in this trial turned out to be around 50. There were less than 1% of patients that were below the age of 18. So really, we didn't see much of a younger population or age group in this trial. The other difference is that therapy could be started within 7 days of symptom onset. So a little bit longer than what was studied in the EPIC-HR trial. But otherwise, these were unvaccinated patients at high risk for progression to severe COVID. And very similar to the exclusion that I mentioned in the EPIC-HR, these patients couldn't have a previous hospitalization or treatment for COVID. They couldn't have really poor renal function or active liver disease. There couldn't be any significant drug interactions on board either. The one thing I will draw your attention to is the use of hydroxychloroquine. So that's an exclusion for this particular trial and really is an exclusion for using this drug, I think, in most provinces. So hydroxychloroquine will decrease the activation of remdesivir, basically making it so it won't be effective, or at least it'll be less effective. And because the half-life of hydroxychloroquine is so long, it's not like we can just stop that medication in order to use remdesivir. So it's more of a, not quite a contraindication, but really a drug we would avoid and not use together. So the efficacy data, again, I'll focus on the top row here, basically very similar to what we saw in that EPIC-HR trial. The placebo group, about 5.3% of patients had a hospitalization for COVID-19 or death from any cause within those 28 days. The remdesivir group, the rate of the primary endpoint was 0.7%. So again, the absolute difference is just under 5% with a number needed to treat of 22 and a relative risk reduction of almost 90%. So results very, very similar to the Paxlovid trial. In terms of safety data, really what we see here is that the results are very similar. There were no statistically significant differences in terms of adverse events. There was a significant difference in terms of serious adverse events. There were more serious events in the placebo group. And it was thought just because of the progression of COVID. More pneumonia was seen in that placebo group. But in terms of actual adverse events or expected side effects, no numerical differences, no statistically significant differences. In practice, though, we did see if a patient was complaining of side effect, more often than not, it was nausea or some type of infusion reaction. And when that happened with that initial dose of remdesivir, then basically the next 2 or 3 days when they were coming back for their therapy, the infusion time was lengthened, and that would help to minimize those side effects. So this table here basically just summarizes the COVID outpatient treatments available in Canada, or at least the most evidence-based COVID outpatient treatments. So I've talked mostly about Paxlovid and remdesivir. On this table, I've also got some monoclonal antibodies. So sotrovimab was used earlier on in the treatment of COVID-19. And Evusheld is a combination of 2 monoclonal antibodies. And really, I haven't seen it used at all. It is available, it is approved, but I'm not sure if any provinces in Canada are actually using it for treatment. So all of the use of these medications are dependent on provincial eligibility criteria. We know already that Paxlovid has to be used within 5 days of symptom onset. The other agents can be used within 7 days with good efficacy. So I talked already about the standard dosing for Paxlovid with the EPIC-HR trial. And anybody with a creatinine clearance over 60 mils per minute will get that dosing. And as I'm sure you're aware, if renal function is reduced below 60 mils per minute, we need to reduce the dose of Paxlovid to the point where patients will get 150 milligrams of the nirmatrelvir and 100 milligrams of ritonavir. Both of these doses will be given at every 12 hours or twice a day for 5 days. For remdesivir, I talked about the standard dosing with the Pine Tree trial, and that's what we use in practice. There is really brand new emerging data saying that it is safe to use this dose in patients with a creatinine clearance below 30 mils per minute. So, this slide is already a little bit out of date, and it was about a couple weeks ago where Saskatchewan made that change. There are some jurisdictions that I'm aware of that with patients with a reduced renal function, so below 30 mils per minute, they will use a slightly lower dose of remdesivir. And then sotrovimab and Evusheld, the monoclonal antibodies, they're a one-time dose. And I won't say much about them simply because they're not being used. In terms of all of these agents, the patients that were studied in the clinical trials were all very, very similar. They were all unvaccinated patients at high risk for progression of their COVID illness. I will point out that, you know, there really weren't very many people over the age of 65. Really 15 to 20% of patients were over 65. These were all really middle-aged populations that were being studied. The other thing that I'll point out is that most patients did not have any immunocompromised status and did not have cancer. So you'll see less than 1%, less than 1%, you know, some trials excluded those patients. So, you know, those are the patients that I really see these drugs used in practice, elderly patients, those that are immunocompromised, those with cancer. So, you know, we're using them in a population that was really not studied in these trials. And I think that's okay. You know, we're definitely seeing observational data and seeing in clinical practice that these drugs are working. I'll also note that these drugs were studied in the earlier variants of COVID. So I talked about the efficacy data for Paxlovid and remdesivir already. Sotrovimab, when it was studied, had really good efficacy data as well. However, it was about January, February of 2022, data started coming out saying that, you know, with the Omicron variant, sotrovimab was not as effective anymore. And that holds true to today. So even though this data looks good, we know that the sotrovimab is not as effective as these agents currently being used. And the Evusheld, and in its clinical trial, it did not show as much effectiveness. So relative risk reduction of 50% compared to the drugs that I've talked about already. And then just to wrap up my section, one final slide is the question about what about low or normal risk patients? And by that, I mean, like just the general population really who are not immunocompromised, who probably have been vaccinated. Is there any benefit to using antiviral agents in that population? Because we know that vaccination already reduces risk of hospitalization or death by about 90%. So I don't have a lot of data to share. The EPIC SR trial was really a study using Paxlovid in those standard risk patients. It was completed, but not published. So Pfizer has a press release that came out, and they basically said in that press release that Paxlovid did not show any statistically significant benefit in that standard risk population. That's all the data that I really have to share. Other than that, we've got an ongoing trial called Panoramic. So it's a UK study that it is examining antivirals in the community to prevent hospitalization. So they're currently recruiting Paxlovid patients right now. And, and so hopefully we'll have more of an answer in the coming months. I can tell you that there is a number of observational data that's been published recently. And what we're finding is kind of three things. One, that with the Omicron variant right now, the hospitalization rates are significantly lower than what was seen in these clinical trials. The other thing that these observational trials are suggesting is that in unvaccinated patients, we're still seeing a relative risk reduction of around 90%. In vaccinated patients, the relative risk reduction is probably closer to around 40%. But again, these are observational trials, so we can use them, but we have to kind of take them with a grain of salt as well. So now I'll pass things on to Ryan.
All right, thank you so much, Darcy. So I'm back, and now we'll be talking about the drug interactions associated with really the ritonavir component. As Darcy mentioned, of course, the ritonavir is used to boost the effect of nirmatrelvir, and that's really because it's a very potent inhibitor of the CYP3A4 enzyme. And we'll go through some of the details. There are some other enzymes and transporters that it does affect, and we'll see sort of how that becomes relevant. So as I did mention, it is a potent inhibitor of 3A4. It does have some weak inhibition of 2D6, but nothing too strong. It is, however, an inhibitor of PGP and as well as the breast cancer resistant protein, the BCRP, which is involved in the absorption of several other medications. And as well as other inhibitors as well, which can play a role. Aside from being an inhibitor of 3A4, it's actually also an inducer of some of the cytochromes, including 3A4 itself, and we'll talk about that in just a second. The one advantage we have is that ritonavir has really been on the market and we of course use it in HIV to boost the protease inhibitors, and it's been used since 1996. So we have really a lot of experience. And we're kind of a bit lucky in our case because we're only using it for a 5-day course. And so the drug interactions themselves become a little simpler to manage. And so if we look in a little more detail, so with the ritonavir itself, it's important to note that it's a rapid and it's an irreversible inhibition of 3A4. So in most cases, about 48 hours, you really have that maximal inhibition. Now, as I mentioned, there's some data suggesting that it's actually known to be also a much slower inducer of 3A4 as well. And that takes about 5 to 7 days to take effect. So in the end, it doesn't really affect us because our treatments are only 5 days, and the inhibition tends to win out over the induction. Now, there's a lot of it could be that this is more of like an auto-induction kind of mechanism, but it's really in the end, in terms of our drug interactions, it's the inhibition potential of ritonavir that's really responsible for most of these. And it's important to note that because it's an irreversible inhibitor of 3A4, so it takes, once you stop the drug, it takes about like 2 to 3 days until your 3A4 levels come back to normal. Now, there are some inter-individual differences there. We all have different genetics and different levels of baseline levels of the enzyme. It might be a bit slower in the elderly population than the younger population, but on average about 2 to 3 days until your 3A4 activity resumes to normal. Now, with the nirmatrelvir component, of course, and that's the active drug that's treating COVID, in and of itself, it's not an inducer inhibitor. It's just simply a substrate of 3A4, and that's why it's able to be boosted by the ritonavir. Now, if you add another inhibitor of 3A4 onto it, you're not going to get any extra effect because it's basically, you're already maximally inhibited by the ritonavir. However, when we're talking about potent inducers of 3A4, and let's say, the patient's chronically on it already, and of course, we, talk about things like rifampin or the anticonvulsants like phenytoin, carbamazepine, phenobarb, drugs like that, where these very strong inducers, those are actually contraindicated because those can actually significantly decrease your exposure to the nirmatrelvir. And so those, of course, are not recommended, and they're completely contraindicated. So what's, general approach to drug-drug interactions with ritonavir? So, as we already said, we know it's a very potent inhibitor, and that's what's going to drive our drug interactions. Now, when you're looking at the drug that you're comparing it to, you got to ask yourselves a few questions. And so, for instance, is the drug extensively metabolized? Because if it's not, well, then the effect of your, if it's only, let's say, 10, 20% affected by 3A4, then the effect of your inhibition is not going to be major for the, the overall outcome. Does it have a significant first pass metabolism? Because those that do are much more affected by strong inhibitors. Are there multiple metabolic pathways? So you have some drugs that are, let's say, metabolized by 3 different cytochrome P450 enzymes, and let's say equally by the 3. So if you inhibit just one of them, the other 2 sometimes can take over, and the overall effect of your interaction may not be so severe. Does your drug have a narrow therapeutic index? So as an example with warfarin, that, a slight modification in warfarin can actually increase, your INR significantly. Whereas, if your drug, if it doesn't, and you could tolerate like a 50 to 100% increase without any risk, well, then you're kind of okay. And then you have to ask, of course, what is the risk of toxicity? So if you're giving it with an antihypertensive drug, as an example, like amlodipine, like where you're going to increase the effect of the drug significantly, well, you can cause significant hypotension in some of your patients, and especially some who are already on the lower side or very well controlled. What's the indication of the substrate? Well, many times some of the drug interactions are not as relevant. So we could just stop the drug, for the 7 or 8 days that it takes for the effect of the full effect of the inhibition to disappear. And can we do any monitoring? So of course, you look at a drug like warfarin, is again, obviously we can monitor the INR a little more carefully during the treatment, and then for the coming days until it ends, and make adjustments in that kind of sense. So we kind of put all this information together to help guide how we're going to sort of approach these interactions. Now, to help us out, of course, we have some great references out there. And for those who have never, seen or used the University of Liverpool one, this is probably the #1 go-to one. And this is a really, they were already known for their HIV drug interaction checker. They have one for the hepatitis drugs as well. And they put one together for this, and this is something that's always up to date. And this is generally the first place I go. And usually what they'll do is you type in all the drugs that you want with, let's say, with Paxlovid, with the ritonavir, or with any of the other ones. And it'll tell you basically, first of all, how severe the reaction is, and suggestions on how to interact with, or what to do, basically. There are a few other ones out there as well. The Ontario Science Table, you can just Google them for sure. They have some great documents where they have great tables and very easy to read on sort of what to do and which interactions are more significant versus others. The NIH in the US has a guide. I came across this one actually for those, if ever you're looking for chemo agents. This is from Toronto, the UHN, and also the Kingston Health Science Center. This is from their antimicrobial stewardship website, and they have actually a great database for onco drugs with Paxlovid. So that's something I found a bit helpful as well. You have your usual micromedics, Lexicomp, and sometimes especially with newer drugs, you don't always get as much detail, and sometimes we just don't know, but that's always a place to look. And then of course always the product monographs. Now, oh yeah, and then there's a couple of others here. This is actually a great reference for cardiovascular medications that just came out. This was just a few months ago, so this is one you could check out. And for those who are a little more interested in some of the more details of the PK of the ritonavir and a little more on some of these drug interactions, you can check out this article as well. And what if you go through those databases and you still can't find the answer? And sometimes you just got to do a little more digging, a little more investigation work. And so the product, so usually what I'll do is if I have, and especially this comes across with a lot of, there's all these new targeted like the targeted therapies and using in cancer or some other new drugs. And sometimes, it's very simple. You look in the product monograph of the drug and you see right away, let's say it's not a substrate of 3A4, it's not at all a substrate of PGP or some of the other transporters. And then, you're pretty much safe that you can use it. There's other specialized references, for onco, you have the BC Cancer, the Cancer Care Ontario, the GEOC in Quebec, that has like little product monographs for each of the different chemo drugs. And sometimes they talk about drug interactions, and that could be very helpful. So, sometimes you got to look around a little bit. Sometimes good old fashioned PubMed, and you type in some drugs, and you're not going to find, let's say if there's some new drug that came out, it was never really tested against ritonavir. There's no reason for a drug company to test a new drug against some of these, but sometimes what you got to do is extrapolate. And so what you will notice that if something is, let's say a 3A4 inhibitor or an inducer, or it's a substrate, if it's more of a substrate, often some of these are tested. Inhibitors and inducers are often tested, let's say, for instance, for 3A4 against midazolam, and you could sort of extrapolate from, because midazolam is very sensitive to 3A4 inhibition, and you could kind of see what the sort of percent increase in that is and maybe apply that to your drug. Digoxin is often used in PK studies for PGP because it's very sensitive. So sometimes you do gotta, because you're not going to find, it's not going to be clearly written, ritonavir increases this by 62%. Like you're not going to find that with new drugs, I promise. And then sometimes you just got to Google. And sometimes you find stuff and you find, articles, you just type the two names of the drugs and you'll get, use with caution, of course, see what your references are and what website this is. But sometimes, and you'll, of course, Google's great and it indexes a lot of the trials as well. And sometimes you just get lucky that way as well. And sometimes you also got to look at a patient's individual risk factors as well. And I'm not going to go through the details. This was really a very over-exaggerated case just to illustrate a point. So this is a lady who comes home from the hospital, just stented, just incidentally diagnosed with Paxlovid on the way out, with COVID on the way out, and they get a prescription for Paxlovid, you get it at your pharmacy. And it turns out this patient so she's on apixaban, she's already on the reduced dose of apixaban, she's on an antiplatelet agent, she has a very low body weight, a creatinine clearance in the 20s, platelets, chronic thrombocytopenia with platelets, let's say 60, 70, and is this a patient, you sort of add these kind of risk factors for bleeding, or, you can kind of add them up. And, with the overall benefit of the drug, in this case, her bleeding risk, by increasing the effect of apixaban, the benefit of the drug may not, equate with kind of the, that effect. So, you have to, you have to also always look at your patient's individual risk factors and then, make your final decision. And for DOACs, and I work in thrombosis, so I get these questions very often, sort of what to do with DOACs. This is really a fantastic reference. This is the Ontario Science Table and their guide to what to do with DOACs and Paxlovid. So I'll just go through this very quickly with you. So on the left, so rivaroxaban is one that's probably the most affected by 3A4 of these, and so they actually, rivaroxaban is considered really a contraindication. Now, for all DOACs, I said, can you use remdesivir? If you can, go for remdesivir. But as Darcy pointed out, of course, that's not always available. And there's even our own hospital, we don't really have infusion centers for outpatient management with remdesivir. So if it's for rivaroxaban, and then you kind of look at the indication. So if it's for AFib, the recommendation is you definitely hold rivaroxaban for 7 or 8 days, and you can actually use edoxaban at the reduced dose, 30 milligrams, and then you could resume your rivaroxaban after 7 days. That's if it's for AFib or a bioprosthetic valve. We'll come back to VTE in just a second. With apixaban, dabigatran, and edoxaban, again, if you're already on the lower dose of these drugs, well, the recommendations are you can safely continue these because you are going to have somewhat of an increase in effect, but for the small amount of time they're using it, it's not going to be clinically significant. Don't forget to look at, of course, as I mentioned, your other patient's risk factors. And so if you're on the higher dose, then they recommend, if it's for AFib, go down to apixaban, edoxaban, and dabigatran, go down to their reduced dose, and you have dabigatran has an extra dose reduction here for 30 to 50 versus if it's greater than 50, and you could probably easily get away with this. If it's for VTE, or if you have an arterial clot, then it depends if it's a high-risk clot or a low-risk. So if it's a high-risk clot, and these are like, if you had a clot within the last 6 months, excuse me, if you have things like antiphospholipid syndrome or active cancer, really the high-risk patients, then they recommend we don't want to really play around. And so in these cases, we would actually recommend to hold the DOAC and just give low molecular weight heparin for the 7 or 8 days, and then you could resume your DOAC thereafter. If it's a low-risk clot, then they recommended to hold the DOAC and just give aspirin. Now, full disclosure, with our group, we had kind of reviewed these recommendations as well, and we made ours for the hospital. We didn't entirely agree with the aspirin arm, and for us, what we would do is just give a low molecular weight heparin, but this is just another way of doing it, and look, there's a whole group of experts that came up with these recommendations as well. And then on the next page of there, they sort of tell you how to switch from one to the other and with all the timing. So you can take a look at that reference. You can easily find it, just Google it, and the Ontario Science Table, DOAC, Paxlovid interaction, you'll see it comes right up. And these have been updated continuously. So there's been a lot of versions of this, and this is the most current version right now. And lastly, just to point out, and this is something we get questioned all the time, because for inpatients, for the ones who are very sick and the ones who are on oxygen, we give therapeutic anticoagulation to these patients. But in the outpatient setting, the ISTH, and I'll just point out, these are international guidelines, these aren't Canadian guidelines, but very, very reputable organization, of course, and they recommend that there is no role for aspirin or DOACs or like low molecular weight heparin at a prophylactic dose to prevent clots in outpatient therapy. So there's really not a lot of data to support that use. And with that, I will pass it over to Heather, who will talk about a more specialized, the immunocompromised population.
Great, thank you very much, Ryan. So my name is Heather Naylor. I'm a pharmacist in St. John, New Brunswick, and I work in our kidney transplant clinic here. I was also redeployed for a few months last spring to our New Brunswick Paxlovid clinic, where we were actually able to have pharmacist prescribers under a collaborative practice agreement with some physicians. So we were working in the clinic, assessing patients and prescribing Paxlovid. So for my section, I'm going to focus on immunocompromised patients, which I'll clarify as organ transplant patients, so lung, heart, kidney, liver, as well as stem cell transplant and patients receiving chemotherapy or other immunosuppressant medications. Have no disclosures for this presentation. So I just wanted to touch base first on vaccinations for immunosuppressed or immunocompromised patients. So you probably won't run into this a lot in practice where most people have had their primary course of the COVID-19 vaccine. But if you do have somebody in practice who's getting vaccinated for the first time, a full primary series for this population is considered 3 doses. And that's supported by an RCT and an observation trial that showed that these patients required 3 doses to have a somewhat similar immune response to the vaccine versus 2 in the general population. So once they've had their 3 primary series vaccines, then they can follow the regular booster schedule that you would follow for the general population. So it's important to note that even if patients are up to date on all their vaccines and they're immunocompromised, it is possible they may not have as good an immune response as other patients would. So reinforcing those other behaviors they can do, like wearing a mask where appropriate and hand sanitizing and that sort of thing. So timing of vaccinations after transplantation, if you have somebody that is going for a solid organ transplant or a stem cell transplant as well, they do receive quite intense immunosuppression at the time of the transplant, just to wipe out your body's immune system so you're not rejecting the organ or the stem cells that you're receiving. So waiting at least a month to give the body some time to recover after that for a cell and organ transplant, or up to 3 months, or at least 3 months after a stem cell transplant before they would get their next dose of the COVID vaccine. And that goes for any vaccinations as well as the flu vaccine and your other standard ones. So the longer they can wait post-transplant, the better, because the more their immune system will have recovered. If you have a patient on chemotherapy, it's probably best to check with their chemo, wherever they're getting their chemo, check with the clinic to see what they recommend as far as vaccinations. But I don't have all of them listed here because each agent, it might be different, but some special ones to keep in mind, rituximab, especially where it wipes out your B cells. If a patient's on this medication, they should wait at least 4 to 5 months after their last infusion before getting their next COVID vaccine. Or if they are going to receive their next dose, ideally they would get a dose of the COVID vaccine 2 to 4 weeks before their next infusion, if you can time it that way. If they're on corticosteroids, if they're below 20 milligrams per day, it's okay to go ahead and give the vaccine. But if somebody's getting those higher doses, if you can wait until they taper down below 20 milligrams per day, that is recommended. Evusheld, I won't talk a lot about because it's really not used, to my knowledge, in Canada. When it first came out, it was hoped that it could be used in the immunocompromised population as more of a pre-exposure prophylaxis. So if you had a patient that was exposed, they could take this to help prevent COVID, or if they weren't a candidate for the COVID vaccine, this was something they could be given if they were potentially exposed. But it's really not active against the current predominant strains, so we're not seeing a lot of usage. So if you have an immunocompromised patient that does develop COVID-19 and you're wondering how to treat, it's simple just for the fact that you're not going to treat them any differently than the general population. So you're really looking at either Paxlovid or remdesivir, and a lot of that will depend on your provincial guidelines and what you have available. But there are some things to keep in mind for both of these agents. Paxlovid, I know in New Brunswick, we really don't see this used in our immunocompromised population because of the drug interaction. So both of these are CYP3A4 substrate. So given with the ritonavir portion, it can lead to really high drug levels. So for tacrolimus, for instance, we've seen, like 4 to 5 times higher than what the drug level should be after patients have started these medications. So if they're going to be put on Paxlovid and they're on cyclosporin or tacrolimus, it's really important that the transplant center knows so that they can manage the drugs and order levels as appropriate. A cyclosporin, if the patient is on that and they're prescribed Paxlovid, they can still take it, but the dose should be reduced by 80% prior to starting Paxlovid. For tacrolimus, you would hold for the duration of the treatment and then check the levels afterwards. But if you're going to use these again, just be very cautious because they can increase the drug levels. And COVID itself, we've been finding, has been increasing immunocompromised patients' tacrolimus levels, especially. We're not 100% sure of the mechanism, but we think it has to do with maybe PJP upregulation, and it can also cause diarrhea in patients, which can actually increase your drug levels. So just something to keep in mind. Remdesivir would be the best choice for this group, but it's not always available. But if you can get patients on this, it's ideal where you don't have to worry about drug interactions, and it can be given within 7 days of the start of their symptoms. So you would still follow regular dosing for the general population, or dose reduce if it has to be adjusted for renal function. So giving as an IV infusion for 2 to 3 doses. And no drug interactions. So again, it's simpler, but may not always be available depending on where you live. I will pass it back to Darcy for COVID-19 rebound.
All right, thank you. So yeah, we just wanted to spend just a little bit of time talking about COVID rebound. And see if I can move my slides. There we go. So COVID rebound it's basically just a recurrence of symptoms, right? So if somebody has COVID-19 and they've started to feel better, there's significant improvement, or they've now tested negative, and then all of a sudden those symptoms rebound, they come back again, or they test positive. That would be a COVID rebound. And really didn't hear much about this until the antivirals started gaining widespread use kind of early in 2022. And after that, I started seeing some case reports being published and wondering what the heck is this all about? So I had some questions around it. Is it drug related? Does this happen regardless of treatment? Why does it happen? And probably most importantly, like, what do we do about it? So really the data that is available is pretty sparse, but I did manage to find a few things, and I'll share with you what I found. So one retrospective review of Paxlovid patients being treated at the Mayo Clinic said that about 0.8% of those patients experienced this rebound at 9 days after finishing their Paxlovid therapy. Of note, all of these patients were vaccinated. All of their symptoms were milder during the rebound, and no hospitalization resulted during this rebound period. The EPIC-HR trial, what they also did in this trial was collect viral load information. And so basically there's a subgroup analysis, and they published this. And what they found is that around 2% of patients in the antiviral group and around 2% of patients in the placebo group experienced this increase in viral load after things had almost normalized. No hospitalizations or death resulted in the patients that had this so-called viral load rebound. So I thought that was interesting, and it was being seen in both the antiviral and placebo group. So why is this happening? Well, this is from a small case series. So keep in mind, this is only 15 patients, but they tried to answer some questions, and they evaluated a number of different biomarkers and COVID activity in people with and without antiviral use, and with and without rebound. And of note, all of these 15 participants were fully vaccinated and boosted. And what they found is about 2/3 of patients, so the majority, reported milder symptoms than their initial COVID presentation. So this is consistent with those other reports that I had found. Interestingly, though, during that rebound, there was less inflammation occurring. So the CRP, this inflammatory mediator, was lower during that rebound period than during the initial COVID symptoms. But the immune function, so the lymphocytes and neutrophils, the T cells and antibodies, they all increased during that rebound period, quite similar to what was seen at the initial COVID symptoms. So that was interesting. And there was no resistance to the Paxlovid that was detected in these 15 patients. So what does this mean? Well, there was one kind of circulating hypothesis before this that maybe it's just an impaired immune response in these patients, and that's why they're having a rebound. Well, these study findings kind of argue against that hypothesis. They also suggest that this is probably not due to viral resistance to medication, at least not at this point in time. And I thought this was interesting. They, just from those 15 patients, they're kind of thinking that this rebound could be due to an immune response against residual viral antigens that have basically just been hiding out in the respiratory tract. But again, this is a very small case series, and their findings are not definitive, but more thought-provoking. So has this just been happening all along? And some of the reports I read was kind of suggesting this. And then I came across this one. So this was a brief report that was examining placebo patients in an ongoing multi-drug trial of COVID therapeutics. So there was 158 patients. And this data is from 2020. So this was when the Alpha variant was circulating and when there were no vaccines. So all of these patients were unvaccinated. And in this report, they found that 30% of these patients had a recurrence of symptoms within 28 days. So this is quite a bit more than the 1 to 2% that I kind of found in some of the other data. I don't know if that just has to do with the specific variant that was circulating at the time, in addition to not being vaccinated. It's hard to say. But nevertheless, all of the patients that had rebound, well, not all of the patients that had rebound, the majority said, you know, my symptoms are a lot or less than they were when I initially ended up with COVID. So the symptoms were milder, and of those having rebound, there were no hospitalizations or death. So I think what this suggests to me is that COVID rebound is occurring regardless of antiviral use. And I think probably what happened is these antivirals came onto the market. We started using them, and people started feeling better quite quickly. These drugs work really well and they work really quickly. So, you know, when this rebound happened, it just seemed to be much more in our face, right? Much more obvious. And we started paying attention to it. So what do we do about it if it does happen? Well, you know, it is expected that these patients are still infectious. So if someone's having COVID rebound, isolation is still encouraged, wearing masks, and no evidence for retreatment. So even if these patients are eligible for antiviral therapy, there's no evidence that we should be using them in this COVID rebound period. I think for a few reasons. One, it just hasn't been studied. And two, because it seems that the rebound happens with less severe symptoms, and limited data is saying that these patients are not really requiring hospitalization. So really what we end up doing is you know, promoting isolation and then just managing the symptoms as required, right? So symptoms are supposed to be milder, but you know, if there's any aches, pains, headache, fever, treating with NSAIDs or Tylenol just as required, fluids and rest as needed as well. So that's what I was able to find about COVID rebound. Now I'll pass things on to Samir.
Thanks, Darcy. Hi, everyone. My name is Samir Kumar. I'm a community pharmacist and owner at 2 independent pharmacies in the province of Ontario in 2 small towns. I was a professor in the School of Health and Wellness for registered pharmacy technicians at Fleming College in Peterborough, as well as a lead clinical instructor at the Doctor of Pharmacy program at the University of Toronto. However, the past 3 years, I've been practicing quite heavily with COVID patients, given the lack of primary care access in my area. And I've also been seeing, prescribing, and assessing many patients with COVID. I have received a speaker's fee from the following organizations that you see on the slide here. So prior to getting into the definition of long COVID, let's first discuss what I like to call the macro, or the big level picture of COVID. On the slides, these are the COVID-related risk factors. And what I want to highlight here is the risk factors on the screen are the types of patients you should have in mind when it comes to elevated or heightened risk factors for more severe outcomes should they contract SARS-CoV-2, severe acute respiratory syndrome, related to the coronavirus. When discussing anything COVID related to my patients, one's concern should not just be about the fact of contracting COVID. Superficially, what I mean is the general cold and flu-like symptoms commonly associated with COVID that otherwise healthy individuals will tell you or tell their friends about. And that's where I think we mislabel COVID as a respiratory infection. And so when someone contracts COVID and they only have these mild aches and pains, but are otherwise okay because of their minimal risk factors, this is only part of the picture. If the virus, the coronavirus, happens to overwhelm the body, and the above risk factors that you see on the slide are present, and the risk, of course, is compounded, and the virus may quickly change from a viral infection to an inflammatory infection, that's when we really worry. And that's when we worry about hospitalizations, outcomes like ICU admissions, ventilation, and of course, worst case, death. Our goal, therefore, should be focusing on prevention to avoid these unintended sequelae. So risk factors for COVID-related complications are written on the slide on the left, but I want to focus on as well are the section of the slide on the right, which is anecdotal experience of further risk factors that patients might not be aware of after being diagnosed with COVID. So patients may think that they're otherwise healthy, but then they're diagnosed with COVID and they have complications. And then after a lengthy stay in hospital, they come out, and then you read in the consult notes that, the risk factors could have been premature birth or anatomical issues that may predispose them to difficulty breathing, like an elevated hemidiaphragm or diaphragmatic hernia. Or patients that are larger or more obese tend to have shorter neck statures. And so there's increased risk of complications related to intubation or even extubation, removal of the tube, and a tracheostomy. And these are all factors that sort of increase the risk of complications with COVID and mental status, of course. COVID-19 risk factors prevention now. So we all know, and we've all learned in school about quitting smoking, the benefits of quitting smoking, exercise, weight loss, and optimal management of chronic conditions. But this also helps with the severity of COVID should we contract it. Now, there is actually some evidence specifically that blood glucose that in patients with diabetes that is controlled at the time of COVID infection is likely to confer greater protection from progression of illness compared to uncontrolled blood glucose, of course, from a lower stress and cortisol level in the body therapeutically. Now, I've had a lot of questions like, does vaccination affect the risk of developing long COVID or prolonged symptoms of long COVID? The short answer actually is yes, it does. And there's a very favorable one. There's evidence to suggest two things. One, that patients with previous vaccination against COVID prior to COVID infection actually reduces the risk of developing long COVID significantly, up to 50%. So vaccination, we know, prevents against COVID infection, but it also prevents against the risk of developing long COVID symptoms. So that's also a nice clinical pearl that I'd like to convince patients of. I know that you're healthy, I know that you're young, and you feel that, if you do contract COVID or your friends that contracted COVID are otherwise healthy and they were fine. But this is also to prevent against the risk of long COVID that patients complain about, which I'll discuss in a few slides. The second point is that furthermore, vaccination, there's actually a benefit of reducing the risk of long COVID symptoms. This extends even if a patient who was not previously vaccinated with COVID and then contracts COVID and then long COVID subsequently, then gets vaccinated after the fact. I want to gear your attention, if you want to read into this in more detail, the Public Health Agency of Canada, PHAC, has a summary of slides and studies regarding this, but it's actually about a 13% decrease in risk of developing long COVID with vaccination after the fact, after contracting COVID. And the odds actually are more favorable and in your favor and add up as well, the more obviously vaccine doses that you receive. So what is long COVID? The definition varies by study or guideline. Generally, symptoms of COVID lasting between 4 to 12 weeks post initial COVID infection. Approximately 40% of patients will have symptoms at 4 weeks, and then that number goes down, and about 10% of patients will continue to have symptoms at 12 weeks post initial infection. Recent studies use the 12-week post-infection, as this is where the treatment is focused. So the coronavirus enters the cell via the ACE2 enzyme, the angiotensin converting enzyme 2, And this enzyme ACE2 is present virtually everywhere in our body, in the heart, in the lungs, in the stomach, in the brain, in the kidneys, in the vasculature. And there's a multifold explanation for how this can cause long COVID, but mainly it's due to the presence of the viral particles and inflammation. Based on the pathophys, this logically makes sense then that the symptoms of long COVID tend to relate to where the ACE2 enzyme is expressed in our bodies. So that's when patients present to the pharmacy or to the clinic complaining of fatigue, brain fog, memory issues, shortness of breath, joint, muscle, and nerve pain, and continued not just respiratory issues, but other neurological issues as well, cardiac issues. Essentially, patients present and they say, one patient said it best actually, and she told me when she came, and she said COVID tended to pinpoint all of the problem areas that I had in my bodies that I was able to keep at bay, but now I'm starting to feel. The question then is, how do we treat long COVID? 3 years into the pandemic, treatment options are minimal for long COVID, other than vaccination. Long COVID is the newest unknown of the pandemic, unfortunately, and there's still a lot of research and data needed. Vagal tone is the activity of the vagus nerve, the 10th cranial nerve, and a fundamental component of the parasympathetic branch of the autonomic nervous system. And this branch of the nervous system is not under conscious control and is largely responsible for the regulation of several body compartments at rest. So the greater the vagal tone, the less the body is in a state of stress and more so in a state of rest. And that's why there is some evidence for singing, yoga, and breathing exercise, which all stimulate vagal tone. Long COVID, of course, is complicated because it's multifaceted and we don't know much about it. And because there is continued evidence being developed currently. And my diagnostician colleagues say that long COVID is a diagnosis of exclusion. After we've ruled out all other conditions, then we can pinpoint and say, the patient must have long COVID. And when patients present, they tend to feel that they need something. So despite the lack of evidence, at least in my practice, or my practice is, I tend to recommend inhaled corticosteroids. So the budesonide, the COVID treatment for the 800 micrograms twice a day for 14 days, or a steroid nasal spray like ciclesonide to help reduce ACE2 expression. So the studies are ongoing regarding that. Of note, there is no evidence that ACE inhibitors or ARBs worsen or trigger long COVID due to their ability to enhance ACE inhibitor expression. There's actually ongoing studies that are looking at the beneficial effect via the attenuation of inflammation through the ACE2 receptor blockade. There is promising data to hint that nirmatrelvir and ritonavir combination, so the Paxlovid treatment, the oral antiviral for COVID, can actually help reduce the risk of long COVID as well. So studies are ongoing. Implications of long COVID. When we talk about increased risk of diabetes and heart attacks and strokes post-COVID or long COVID specifically, it makes sense to pathophysiologically because our bodies are in this post-inflammatory phase. So patients with long COVID or COVID in general have an increased risk of diabetes and heart attacks and strokes compared to their healthy counterparts who did not contract COVID at all. So what I want to mention here that's also interesting that I was reading recently in the CDA, the Diabetes Canada, the Canadian Diabetes Association guidelines, is that there's multiple articles and hypotheses to justify this finding of increased risk of developing diabetes. Some studies argue that it may be due to patients who already had these pre-existing undiagnosed conditions, but due to the lack of diagnosis and follow-up during the COVID pandemic era, when primary care practices were closed or just virtual consults were happening, not a lot of blood work was being done, or due to lack of access to healthcare previously prior to being diagnosed with COVID, or after they've been admitted in hospital, then there's a lot more plethora of testing being done, and then they determine and identify the diagnoses. So there's a reputable article that you can find recently in the past couple of months. Now we want to shift gears and discuss a case that Darcy and I will go over.
All right, so we've got Mr. N here. So Mr. N is a 72-year-old male with COVID positive rapid antigen test as of yesterday. And he reports that his COVID symptoms started about 3 days ago. So currently he's experiencing some nasal congestion, headache, some change in taste, some mild shortness of breath, but just with exertion, and a bit of cough. He also notes that he's a bit more tired than usual as well. He denies other symptoms of COVID-19, and you specifically ask about severe symptoms. So he does not have any severe shortness of breath or shortness of breath at rest or chest pain. So, you're not as concerned about, him having symptoms that would lead him into the hospital. You think if we're going to manage this, we can do it as an outpatient. He has been fully vaccinated. He has the Pfizer vaccine ×4. The last one was about 4 months ago, he says. And actually, in this case, his family physician is the one contacting us. And she's thinking about prescribing Paxlovid and notes that there's a number of drug interactions. And she just isn't quite sure how to proceed. So she just wants our help with this. In terms of his past medical history, Mr. N has rheumatoid arthritis, hypertension, dyslipidemia, atrial fibrillation, and BPH. He's not previously had COVID that he's aware of and has never been treated with any kind of COVID therapy or antiviral. And he has no drug allergies that he's aware of. So these are his current medications. We've got him on methotrexate, folic acid, and hydroxychloroquine for his rheumatoid arthritis. He's on perindopril and amlodipine for his hypertension, atorvastatin for the dyslipidemia, tamsulosin for his BPH, and apixaban for AFib. So I will note, in a lot of jurisdictions, being on an immunosuppressant agent could potentially qualify him for Paxlovid. And, this is low dose immunosuppression, but, in Saskatchewan, I'm aware that we do allow methotrexate to, be one of those eligibility criteria. Other things that you probably want to know. So his renal functions is sitting around 65 mils per minute. He is obese. His BMI is just over 31. His liver function tests have all been within normal limits, and he's got no history of liver dysfunction that you're aware of or that his physician kind of discloses. So when you talk with the physician, she says, his blood pressure was a little bit elevated in clinic today, but his usual at-home BPs are sitting around like 130 over 75, somewhere in there. Heart rate was a little elevated today, but he's symptomatic for COVID. And that would also explain the slightly decreased air entry that the physician heard in both of his lung fields. So we've got a couple of polling questions. So based on his presentation, from what you're aware of in your jurisdictions, is Mr. N eligible for treatment with Paxlovid? And really, before we jump in and start looking up drug interactions, this should probably be the first question, right? Can he actually go on treatment? And I mentioned earlier, while you're putting in your answer here, that really eligibility is going to be dependent on provincial criteria. So answers might vary a little bit. So let's see what people say. So most people are saying yes, or maybe, but I need more information. Some people are saying no, and that just might be based on, what your provincial criteria is. I think most jurisdictions, and I can speak for Saskatchewan because that's where I'm from, would put him as eligible for Paxlovid. He's fully vaccinated. Yeah, he does have a number of risk factors, but because he's on the methotrexate, that would kind of tip the scales in favor of treatment, at least in our province. Absolutely. So the next question. So if we're going to assume that, yeah, sure, he is eligible, we might consider treating him, then based on your knowledge and experience, are you comfortable assessing this patient for drug interactions and providing a recommendation to his physician? Maybe you've got lots of experience with this, maybe you don't, and we're just curious to see where you're at this point. Okay, so a little bit of a mix, but the majority of people are saying, yeah, I can do this. Or, I want someone else to double check my work. I want to, pick somebody's brain, which is completely fair. These drug interactions can be complex. So this is how we would approach it, and I'll pass things over.
Okay, so based on the medication list that he has, the amlodipine, it's metabolized by CYP3A4. So Paxlovid is expected to increase the drug concentration by about twofold. So we can suggest two things. We can suggest that he cut his tablets in half and take half the dose for 7 days, the 5 days that he's on the Paxlovid, as well as the 2 days afterwards, because of what Ryan was saying for that delayed inhibition. Or alternatively, since his blood pressure is typically not that low and not acutely elevated now, amlodipine dose can be continued as is, and just advise the patient to monitor for the blood pressure symptoms and monitor the blood pressure as well, especially because it is a low dose of the amlodipine. As for the apixaban, same thing, metabolized by CYP3A4, so the concentration is expected to rise when used and therefore increase bleeding risk. So based on what Ryan was saying in his section, we would reduce the dose from 5 milligrams twice a day to 2.5 milligrams twice a day for the next 7 to 8 days. So again, for the 2 to 3 days post Paxlovid treatment. As for the tamsulosin, we would recommend to hold for 7 days because Paxlovid is expected to increase its concentration by about 3 times. Most patients are okay and don't have too much urinary retention or BPH symptoms. You may also consider dosing every other day for 7 days, or just maintain at the current dose and monitor. For the tamsulosin, the controlled release tablet monograph states that you can increase up to 0.8 milligrams once a day, and he's at 0.4. So you can assess the situation. Of course, in some of my patients, I have actually advised to just continue as is with no issues whatsoever. The atorvastatin, you'd recommend holding the statin again for a week, or you can adjust, and based on the Ontario Science Table guidelines, you can tell the patient to reduce, or you can adapt the dose to 10 milligrams once a day, maximum dose while you're on the Paxlovid. The only thing is that for compliance, some patients may forget to restart it, and that's why I tend to reduce the dose for the majority of my patients. Hydroxychloroquine, weak drug interaction, so it's not likely to be clinically significant. It is okay here, but a reminder echoing from Darcy's section that use is not recommended or contraindicated with remdesivir.
Just as you flip the slide there, I was just going to make a comment. One of the questions was, where did you get the information for these drug interactions? And I thought it might be worth addressing now. And I know when I started looking up drug interactions, when I first started working with the therapeutics group, I would often have 3 different things open on my screen. I'd look at LexiComp, I'd look at the drug monograph, I'd look at Liverpool, because sometimes Liverpool didn't have all of these drugs, but Lexi did. But Liverpool has better information in terms of how to deal with these. So, this information is coming from a variety of sources. And I would agree, Ryan had mentioned that Liverpool is a great resource. And it would probably be my staple if I was only going to use one, but I'm often looking at more than one just to confirm and help kind of add more weight to my clinical decision.
And just to even further add to that, like medicine and pharmacy is as much an art as it is a science. And for example, the other day for a patient, they were on rupatadine or Rupall, which is a CYP3A4 substrate, not in the Liverpool, not in the Ontario Science Table. I'm from Ontario, so I'm biased. So what I would do, exactly what Ryan was sort of outlining for us, is I went into the LexiComp and just Google or control found, substrate of CYP3A4, and you would hold it if you're on Biaxin or sclerothromycin. So based on that same logic, extrapolating the evidence, I would also hold it for the 1 week while on the Paxlovid as well. Okay, what if questions? What if this patient was on a potent inducer of CYP3A4 like phenytoin or carbamazepine or phenobarbital? Of course, this significantly reduces the plasma concentrations, so an easy contraindication. We can't do it, unfortunately. What if this patient's last blood work for renal and hepatic function was 18 months ago, which seems to be the pattern post-COVID, like what I was mentioning in my slides, limited access to blood, to labs. What do you think you would do here? Darcy, do you want to touch on this part?
Yeah, sure. So really, it's going to depend, and I'm going to be looking at what is available, how long ago it was, and what kind of trends are apparent. So, if this was 18 months ago, I'm going to look back maybe 3-5 years, depends what's available, right? And if renal function has been very, very stable over that period of time, I'm not going to be too concerned, right? If the last one was 65 mils per minute, but was 18 months ago, but I know that everything was stable up till then, I'm not expecting a drastic decrease. I know in the EPIC HR trial, they included patients, down to 45 mils per minute with that standard dose. So I'm not too concerned. With hepatic function, I'll often see a few years in between LFTs, usually because the physician checked it. There hasn't been any symptoms suggestive of liver disease, and they didn't think to bother checking it again. So again, if I'm looking to make sure things are stable, I want to make sure that if I do have any concerns, I would be discussing with the physician. Are they thinking that there's ever been any liver dysfunction? If there hasn't, and the test 18 months ago was fine, I'm not going to be too worried. But, if these tests have been variable, or if there's any concern that, something acutely has changed, I would definitely push to get that patient's blood work done before prescribing therapy. So it all depends on the situation.
I had a few weeks ago a patient who knew that they had severe hepatic impairment. They didn't say that they had a child pug score of C or severe to know that it's contraindicated, and we ended up opting against Paxlovid. But just after a conversation with the prescriber, that you could determine that as well. For example, on UpToDate, there's a child pug score calculator for severity of liver disease in adults that the majority of things we can sort of deduce on our own too, just based on blood work, if it's available. Okay, I think there was that was it. So the key learning points, just to summarize here, we want to encourage prevention through vaccination. If there's anything we can remember from this presentation, vaccination, vaccination, vaccination. It helps prevent against COVID, prevent against hospitalization, complications of COVID, and long COVID symptoms. And of course, the appropriate use of medications for treatments are key roles for the pharmacist for COVID-19. Paxlovid for my patients and in my practice has been honestly a game changer and a lifesaver. And I do want to just mention that when patients don't necessarily know that they qualify or that they're eligible for Paxlovid, they will call and they say that they're sick, or they want a recommendation for cold and flu over-the-counter recommendation. So train your staff, if you work in community or even in the clinic, to always screen for COVID or ask about COVID, or if they've tested for COVID, number one. And number two, if you're treating a partner for Paxlovid that's positive, ask them if you can also assess their partner as well. More often than not, they will read online about, incorrect criteria about whether or not they could be eligible for the antiviral treatment. So we have to be the ones to step up and offer it to patients. That's actually how I've prescribed the majority of mine patients and even know about it. So patients' existing medication regimens should also be assessed prior to initiating COVID antiviral treatment in order to prevent potential drug-drug interactions. Unfortunately, there's no treatment yet for long COVID. Inhaled corticosteroids and steroid nasal sprays may provide some relief of respiratory inflammation, as well as practicing of that vagal tone with singing and exercises and breathing exercises. We're still learning vaccine efficacy over time, antivirals, COVID rebound, long COVID. That's the beauty of our profession. Thank you, everyone.
All right, thanks everyone. So we are gonna go straight to the chat here because we have some really awesome questions, quite a bit. I love them. People are answering and stuff like this. So we're gonna go through everything and we'll get to them. For those who cannot stay, for those who want to stick around just for a few more minutes, we'll get through everything, I promise. For those who cannot stay or whatever, I completely understand. Thanks for joining us, but let's get through this. So the first few questions deal with Paxlovid and also remdesivir in severe renal and hepatic dysfunction. And so some of the questions are, can we use them? So I'll just point out that, so technically these are not, so use in renal failure or severe hepatic failure, including Child-Pugh C, they're actually not listed as contraindications, but rather precautions. And so, I've heard, sometimes pharmacists will completely shut it down and say, no, you absolutely cannot. And sometimes you really got to look at the risk benefit. So, and I know a lot of people answered some of these in the chat, and in their jurisdictions, they are using it. And we for sure in Quebec, we are using, and it is off-label. I should have to point that out for legal purposes. It is off-label use to use it in severe renal impairment. But we do that. We do it for remdesivir, including our dialysis patients as well. I don't know if anybody has anything to add on that note.
I'll just say, like, there's certainly kinetic data looking at Paxlovid in end-stage renal disease and poor renal function. And I think a lot of the dosing recommendations in that population is just based on that kinetic data. In Saskatchewan, it's a pretty hard no. If your clearance is below 30, patients are not eligible. And I think that's simply because remdesivir is now being used in that population. And so there's another option.
All right. And at the beginning, someone asked also about other contraindications to Paxlovid. There's pregnancy. I know breastfeeding as well. I know drug interactions are listed as contraindications, of course. I think that's off the top of my head. That's all I can think. Oh, and of course, allergy, the usual hypersensitivity reaction, of course. But I think that's about it, if my memory serves me correctly. And then someone asked about crushing or dispense it, like if you can dissolve it or something like that. I was not aware. So someone did answer in the chat that the answer is yes. I was not aware of that. I don't know if you guys, did anyone else do that in practice?
So I think, if you read the monograph, it says don't crush, don't split. These aren't modified release tablets. So I've read information as well that it can be done. And I know it's being done in practice, but I haven't seen any data to support, but it should be okay. Just in my mind anyways.
All right. Yeah. Sorry?
I was just saying, especially in the context of long-term care facilities for the crushing of the tabs.
Definitely. Next, someone asked if we could share the slides. I don't have a problem with it. David, maybe David, if you can answer that in the chat for us. I'm not sure, but I believe there's a way of doing that. We'll find out. Is hypertension a side effect of Paxlovid? No, not that I've seen. It's really more on the interaction side if it's going to be given with something, but there's no specific thing on that name. Ontario Science Table, most used for docs. Yeah, are there other resources? Yeah, well, most of the resources that I mentioned, so the Ontario Science, they published a really nice and beautifully graphic, and it was easy to read. By the way, someone wrote in the chat that they got dissolved by the Ontario government, and I did not know that. I'm sorry. It's horrified by that because I just love their references and their resources, and they're always keeping up to date. So thanks for, I think it was, Colleen that pointed that out. So thank you. That's very unfortunate. But even, the Liverpool reference does show also, and the recommendations are generally similar. I forgot if Thrombosis Canada had something on that. Sorry, David, I apologize. I can't remember. But most of them really generally say the same thing. So someone asked about the price. Yeah, the $800 per regimen is what I've seen as well. I think that's, it's amazing the price of this drug. But that is the price.
Just to add on, about what Colleen was saying about the Ontario Science Table has been dissolved by the government, which is true. However, University of Waterloo and University of Toronto, they still do update it regularly. So when you do Google it, and that's why you're probably seeing an up-to-date version, it's just not called the Ontario Science Table anymore. I think the last update for the Ontario Science Table was September 2022, but there's more recent for Paxlovid and the DOACs in December or so. So they are still being updated by our colleagues, which is very nice.
Oh, awesome. Thank you. Good news. I like that. Someone asked where patients get the rapid test if they don't have any readily available. So that's something I know that was just announced where the federal government will no longer be supplying that to the provinces and this and that. So this is really going to be every province doing their own thing. I know Quebec has already announced that soon it won't be available in pharmacies, and it'll be high-risk patients like the elderly or people with certain risk factors that will be able to get them at testing centers, places like that. So this is really going to be different provinces doing different things, I guess. Yeah, so that'll, everyone will do something different here. Yes, and the next one, it was a clarification of what I said. So we give inpatient, so we give anticoagulation to all, like therapeutic anticoagulation to all hospitalized patients on oxygen. So those are quite sick, not if they're in the ICU. And this is based on there are several RCTs that came out that showed the benefit. What I was referring to, so on the outpatient setting, this has actually been studied. So there's several studies that have come out that have actually shown that there is no benefit to even giving prophylactic doses or aspirin in the outpatient setting, so that and probably just because the overall risk, especially in the patients who are less sick, isn't as high. So you would probably have a number needed to treat that is so elevated to show any, and you might prevent a few for sure, but from a cost effectiveness and just a side effect profile, there's just no evidence showing that would be the way to go. So Faisal also had a question, this is for Heather. So tacrolimus is not a contraindication with Paxlovid, so we switched to remdesivir.
So yes, correct. It's not contraindicated, but some provinces, for instance, New Brunswick, where I live, our committee has said don't use it because of the drug interaction, but Ontario and BC occasionally will use it. So weighing those risks versus benefits and working with the transplant center, but it's not common to see it prescribed.
Thank you. The next question from Colleen was, if the patient is unclear about the timing of the start of the symptoms and had a positive test and is high risk, how crucial is it to determine the 5-day window, or is 7 days reasonable? And what happens if it's the weekend? Someone want to take that one?
I think it probably is going to depend on the province. I know in Saskatchewan, at least last year, we were very sticky. If you're like 5 days plus 3 hours, sorry, the data doesn't support it. We would have other options like remdesivir for those particular patients. So at least in Saskatchewan, we were pretty picky. I still think we're being pretty picky about that as well.
Same in Ontario. And it's the same argument that some patients say, immune compromised or transplant patients going on a cruise and they want a prophylactic dispensing of Paxlovid to have on hand. Can't do it.
Right.
Cannot do it.
Same for us as well. Yeah. Next, for moderate symptoms, not mild symptoms, would remdesivir be for 3 or 5 days? So Darcy, when he presented the pine tree, so the 3 days really kind of like, it's kind of equivalent to the same indications of Paxlovid in the end. So the 5-day regimen, the original regimen of remdesivir, that's the ones that those are hospitalized, who are on oxygen. So we use the 5 days in them. And for even us at the Jewish General where I work, because we don't use Paxlovid as much for inpatients, just to simplify, we actually use remdesivir. So we'll use the 3-day regimen for patients who are not on oxygen, and just sort of to prevent, with the goal of preventing the progression of the disease. So we still very much do that to our patients. And we still have a few also that will get Paxlovid as well once in a while. Yeah, so that was that. We use, so we had someone else who, exactly, the remdesivir for patients on oxygen. This is from Allison. I've heard about quite a bit of blood glucose fluctuations in people with existing diabetes, hypo and hyperglycemia. Sorry, Allison, if you're still here, are you referring to for patients on Paxlovid or just COVID in general, or? Okay, we'll see. I know, sorry, I'm going through, I don't know if someone could see it or.
I think I saw her posting that when I was discussing my slide about when you're diagnosed with COVID, then you have increased risk of developing diabetes. And when I was discussing the CDA guideline situation.
Perfect. Oh, this is another great one from Colleen. Yes, this is something I've seen. There are some articles on metformin early on to prevent long COVID. So we have metformin, we have fluvoxamine, we have the inhaled steroids. Someone want to grab this one?
I have not heard of this yet, to be honest, but I know metformin, like for PCOS and now with prevention against obesity and antipsychotics. So now I guess to prevent long COVID.
Yeah, the data is it's not very robust, to be honest. And this is a lot where we're looking at, like Paxlovid, which is like an $800 treatment. And, we're talking about the Canadian kind of environment. And there's a lot of places where, in the world where, putting $800 a treatment is not maybe an option. And, we do have some data, and while it may not be as robust, or actually sometimes because of, especially with the current population, with everyone's immune, maybe it's just as good at the, and I guess time will tell, but where some of these alternative therapies like metformin or, the fluvoxamine and might be an option in some of these patients. And I know that is in some places, and there's been some uptake in some of the guidelines and stuff like that. So we'll see. What the metformin data is generally new. It came out quite recently. So we'll see where that goes. Do you see LFT rising with remdesivir? I have personally seen it, but it's rare. I haven't seen it very often. And we use quite a bit of it at the hospital. It has happened, but really, I have very rare. Severe hepatic, yeah, now we talked about severe hepatic. Oh yeah, you were at severe hepatic impairment with Paxlovid. When was it changed? It does show contraindication with Paxlovid. I
just looked at the monograph. It just says not recommended. The Ontario Science Table also says in Class C, not recommended. I mean, I know in my case, I said that we ended up opting against Paxlovid. For other reasons, I didn't mean to say that it was a contraindication, but we just opted against it. But no, not contraindicated.
All right.
This is what you said as well, Ryan. It's just not recommended, but not.
Yeah, exactly.
Not
perfect. Excellent. So I think that's it. I know we went over, and thanks everyone for sticking around, and a big thank you for joining us. We really appreciate it. Again, there is David put the link to the evaluation. You'll also get it by email, and then you'll also get the credits for the CCEP. So we thank you very much. A big thank you to Thrombosis Canada for hosting this, and we wish you all a very good night. Thanks for joining us.